Hello, welcome to my YouTube channel. Today we're going to talk about a very high yield topic which is frequently tested on the board exams. And I'll give you some solid information how to tackle a USMLE style question and how to augment your score in the optimal way. So let's get started. So this is a 19 years old girl who was previously healthy, and over the past 6 months, she is complaining of neurological symptoms which are increasing gradually. Initially, she had difficulty in jumping, and she felt tingling sensation in the toes, which progressively uh, progressed to her, spread to her left foot. Over the past 2 weeks, she has stumbled and fallen several times. Examination of the upper extremities shows normal findings. Deep tendon reflex are absent in the lower extremities. She is unable to heel walk and has mild difficulty walking on her toes and rising from her low squatting position. So I'm going to give you a very important and high yield factoid, which might sound a bit tangential, but it is really important to mention that in the USMLE and also in the clinical practice, your patient is not going to tell you that, doctor, I'm going to have a problem with my proximal muscles, right? Or I'm having a weakness of my leg muscles. I'm having a lesion of my common peroneal nerve. So you have to focus on the wording, on the phrases given in the clinical vignette, and then you have to deduce the information. So they are not just going to say it straightforwardly that the patient is having proximal myopathy, patient is having problem with the uh, any nerve lesion. So you have to think about it, you have to deduce the information. So for example, in this case, you can see that these phrases give you a clue that patient is having a problem with or weakness in her uh, muscles of lower limb, but her upper limb is fine. It is quite fine. And then the question mentions that she is unable to heel walk. It means she is unable to use her uh, muscles in the anterior and lateral compartment of the leg, right? It means she is having a problem with her common peroneal nerve. And again, question says that she is also having problem with the toe walking. She is unable to walk on her toes. It means there is also problem with the tibial nerve, right? So tibial nerve is injured, common peroneal nerve is injured, and she is also having problem with the proximal muscles, like you can say gluteus medius, gluteus maximus. She is unable to stand from the sitting position, from the squatting position, right? Position sensation is normal, but there is a bit pinprick feel is less sharp, and occasional uh, light touch stimuli are missed over the toes. So there is some abnormality related to sensory system. And then they have performed a nerve conduction test, which showed a decreased velocity or decreased speed of the nerve conduction. Which of the following is the most likely diagnosis? So the question says that the patient is having progressive ascending paralysis, right? Ascending flaccid paralysis, because deep tendon reflexes are also absent. So patient is having ascending flaccid paralysis along with minimal sensory involvement for the last 6 months. So what is the diagnosis? Okay, as I have mentioned, patient is having ascending flaccid paralysis. Now you can say, okay, it is GBS, right? No, there is a technicality involved. There is a minutiae involved. They have given a history of 6 months. So GBS is basically acute inflammatory demyelinating polyradiculopathy. Acute, which is less than 2 months, right? Less than 2 months or less than 8 weeks. And this chronic inflammatory demyelinating polyradiculopathy is greater than, if the disease duration is greater than 8 weeks or 2 months, then it is labeled as CIDP, chronic inflammatory demyelinating polyradiculopathy. So in this case, they have given a history of 6 months. So it means patient is having chronic inflammatory demyelinating polyradiculopathy. So CIDP and AIDP, option A and option D, they both are similar, very similar, right? But the duration of the symptomatology, the duration of the disease process is going to differentiate between these two entities, between these two clinical entities. If the duration is less than 2 months, then it is GBS. If duration is greater than 2 months, then it is CIDP, option A. So in this case, option A is correct. So diabetic neuropathy, this patient is not having diabetes, and for a patient to have diabetic neuropathy, like the USMLE style question or also in clinical practice, they're going to give you a patient who is chronically having diabetes mellitus, uncontrolled diabetes mellitus for like for the last 2 decades, and then patient would be having some genitourinary problems, problem with incontinence, a problem with continence, and problem with the defecation, and also a problem with the mobility, problem in walking due to peripheral nerve damage. So this is not the case here, so we can exclude this option. Epidural spinal cord metastasis. So this option would be in the case where the patient is having some kind of malignancy, and that malignancy has metastasized to the vertebral column, and then that metastasis is going to compress the spinal cord, and because of the compression, patient is having some neurological manifestation. So this patient is quite fine and quite healthy. She is not having any malignancy. So this is going to be a wrong option. And GBS, I explained that the duration is greater than 2 months, so it is not the right option here. Multiple sclerosis, option E. Multiple sclerosis would present in young females because it is an autoimmune disorder. It is more common in females and young females in the reproductive ages, but it would present with a clinical presentation of there would be some neurological manifestations such as weakness of the left limb, and then this neurological weakness or neurological manifestation would be spaced by time and space. So for example, initially that lady developed a weakness of left foot or left whole limb, lower limb, and then after some time it resolves over time, and then after some time she's just healthy, she becomes healthy, and then say after 1 year, 2 year, or after a stressor event, she again develops symptoms, and then at this time, instead of in the same limb, she is going to have symptoms in the upper limb, right upper limb, or any other region which was not involved previously. So the disease process is going to be, or the neurological lesion are going to be spaced by time and by space. So they described it as remitting and relapsing pattern. So this is the most common variety or variant of the multiple sclerosis, remitting and relapsing pattern. So in the USMLE, they are going to test you on this concept. They would tell you the patient had some eye manifestation, optic neuritis, and then it resolved over time, and then she developed some weakness of the lower limbs. She developed some genitourinary problems, some urgent continence like this, and then it resolved. And now she was having a viral infection, and after the viral infection, she developed a paresis of the uh, left arm. So, what is the diagnosis? So, all these manifestations, all these presentations, they are spaced, or they are differentiated, or they are separated by time, and they are also separated by space. They are not in the same region. So, a single neurological lesion cannot explain the finding. So, this is not the case here. So, multiple sclerosis is also ruled out. I hope you enjoyed this video. Please give this video a like, share with your friends, and subscribe to our YouTube channel. Thank you so much.